Now let's dive into what this test is and how it is performed. The test consists of adding triiodothyronine T3, labeled with radioactive iodine, typically the I-131 isotope, to the patient's serum. After a short incubation period, radioactive iodine labeled T3 binds in part to the available hormone-binding sites of binding proteins, mainly thyroxine-binding globulin. The free or unbound radioactive iodine, labeled T3, is then absorbed onto an anion-exchange resin. Subsequently, the radioactivity on the resin is measured in order to estimate the T3 resin uptake. Next, we will review the interpretation of this test. In order to understand how to interpret the test, we must first review the double equilibrium equation for the T3 resin uptake test. This equation shows that radioiodine labeled T3 bound to binding proteins in the serum is actually in equilibrium with unbound radioiodine labeled T3 and bound radioiodine labeled T3, which is a portion attached to the resin. For a patient without underlying thyroid dysfunction, about 25% to 35% of the added radioiodine labeled T3 goes onto the resin. Inspection of the double equilibrium equation shows that more radioiodine labeled T3 will go onto the resin when few binding sites on thyroxine-binding globulin are available. This is the case in hypothyroidism, since the excess thyroid hormone occupies binding sites on thyroxine-binding globulin that are normally free in normal physiology. As a result, a decrease in free binding sites occurs when the amount of binding protein in plasma is diminished, or when binding sites are occupied by a drug such as salicylate. Now let us assess our understanding of this test in another case scenario. What will be the expected T3 resin uptake in a patient with hypothyroidism? It is important to realize that in hypothyroidism, due to a decrease in the serum thyroxine concentration, many binding sites on thyroxine-binding globulin will be free or available to bind the radioiodine labeled T3. Consequently, a larger fraction of the radioiodine labeled T3 will be bound to thyroxine-binding globulin, and correspondingly, less will be bound to the resin. The measured radioactivity of iodine on the resin will therefore be low. This will be interpreted as a low T3 resin uptake. Conceptually, a low T3 resin uptake will also be observed in cases where the overall number of available binding sites is increased. This scenario will be expected in the setting of increased concentration of thyroxine-binding globulin. Causes of increased thyroxine-binding globulin include exposure to estrogen or oral contraceptive treatment. This is because estrogen mediates increased production and decreased clearance of thyroxine-binding globulin. A simple way of remembering an accurate interpretation of the T3 resin uptake is to know it has a direct relationship to the serum concentration of thyroxine and an inverse relationship to the concentration of hormone-binding proteins, mainly thyroxine-binding globulin. Next, we will review a few case studies. In this case, a euthyroid patient. In a euthyroid patient, there will be free hormone-binding sites on TBG, or thyroxine-binding globulin. Therefore, adding radioiodine-labeled T3 to the serum will result in a scenario where a fraction of it will be bound to these free sites. However, 25 to 35% of it will remain unbound and will be absorbed by the resin. Thus, the radioactivity on the resin will be measured to arrive at the T3 resin uptake value. In this next case, the patient is overtly hyperthyroid. As such, most of the thyroxine-binding sites, or I should say thyroid hormone-binding sites, on thyroxine-binding globulin will be occupied by thyroxine. As a result, when radioactive iodine labeled T3 is added to the serum, most of it will be unable to bind to thyroxine-binding globulin. Thus, the majority of it will be absorbed by the resin. The measured radioactivity on the resin will be high, typically above 35%. In a patient with hypothyroidism, there will be mainly free or unoccupied binding sites on thyroxine-binding globulin. When radioiodine-labeled T3 is therefore added to the serum, most of it will occupy these free sites. Thus, a small fraction of radioiodine-labeled T3 will bind to the resin. The estimated T3 resin uptake value will typically be less than 25%. Finally, let's evaluate your understanding of this test by examining what happens in the setting of abnormal thyroxine-binding globulin levels. For example, in a pregnant euthyroid patient, estrogen will be expected to increase the amount of thyroxine-binding globulin. This was mentioned earlier. This will mean that there will be a large number of unoccupied hormone-binding sites available on TBG for radioiodine-labeled T3. Most of the radioiodine-labeled T3 will bind to TBG, leaving a small quantity in the serum. Thus, the T3 resin uptake will be low, usually below 25%. This case involves a euthyroid patient with low TBG at baseline. As was previously mentioned, a low level of TBG implies a restricted number of hormone-binding sites available to bind radioiodine-labeled T3. Most of the radioiodine-labeled T3 will therefore bind the resin. The T3 resin uptake will be expected to be greater than 35%. Next, we will discuss the concept of the free thyroxine index. The combined evaluation of the total T4 concentration and the T3 resin uptake allows a correct diagnosis of thyroid function even in the setting of expected variations in hormone-binding proteins. The combined test thus gives us a better idea of the concentration of the functionally relevant free thyroid hormone. The free thyroxine index is an abstract number that correlates very closely with the free T4 hormone concentration in serum. It is estimated based on the equation shown. It is worth noting that the free T4 index is expressed without units. Also, the T3 resin uptake in the control group is assessed by calculating the mid-normal T3 resin uptake for all samples evaluated at the laboratory performing the test. The free thyroxine index was relevant at a time when the direct assessment of free T4 was labor-intensive and cumbersome. Since the discovery of high-throughput radioimmunoassays for the assessment of hormones, free T4 evaluation is easy in routine practice. Consequently, thyroid function tests such as the free thyroxine index and T3 resin uptake are discussed due to their historical significance. Interestingly, there are some parts of the world where these tests continue to be relied on for the management of thyroid disease. I hope you found this video on T3 resin uptake informative. If you want to see more of our videos about endocrine pathophysiology, then hit the subscribe button. Do not forget to click the bell icon so you will be notified when future videos in endocrinology are uploaded. Thanks for watching.